So we're now going to talk about my nightmare and the nightmare of virtually every anesthesiologist. And that's the failure to secure the airway, because this can lead to death, can lead to immediate cardiac arrest, and it can lead to permanent brain damage, chronic vegetative states from cerebral hypoxemia. This is the single most important aspect of the anesthesiologist's job. And really, it's what we get paid for. If we fail in this respect, we failed in every respect, because obviously if the patient doesn't survive the anesthetic, having surgery is kind of a waste of time. We're going to talk more about standard intubation techniques and techniques used in the difficult airway situation in Lecture 5 under general anesthesia. But some of the warning signs, just to give you a preview of what's going to happen, include poor mouth opening. Normally a mouth should open 5-6 centimeters, but if it only opens less than 2 to 3 centimeters, that's a warning sign. Poor neck mobility, so the inability to extend the neck is a major concern, and it's common in elderly people, so we see it a lot. Small or deformed mandible, this can happen in congenital anomalies, it can happen with damaged mandibles, it can happen with people who have very poor dentition and have a large overbite and a poorly developed mandible as well. We measure the mentothyroid distance, which is the distance from the tip of the chin to the thyroid cartilage, which is the large cartilage in the neck, the airway. And if it's less than 4 centimeters, we know we may have a problem. Short, thick neck can be a problem. Fixed flexion deformity of the neck is seen in some diseases such as ankylosing spondylitis. And anything that interferes with normal airway throughput, such as a tumor, an abscess, or hematoma, can all lead to difficult airway situations. Most anesthesiologists take the view that we should always be conservative when approaching the airway. And if there's any doubt that we can get a tube in the patient asleep and paralyzed, then we shouldn't put them to sleep and we shouldn't paralyze them. We should do an awake intubation. Now, awake intubation sounds like a terrible technique. I can just see all of you gagging and thinking all kinds of horrible things about the person who would subject you to this. And it sometimes isn't very pleasant. I'll be very honest about it. But it is the absolute best way to prevent failure in intubation, because the patient is awake and maintains his or her airway through the whole procedure. So basically, if you are concerned about getting a tube in or you think it isn't going to happen, then you should definitely do an awake intubation. There are other techniques that allow us to make somewhat difficult intubations easier. And these include airway adjuvants available to use immediately. A stylet, which is a malleable device that goes through the tube and gives the tube shape. A bougie, which is an even longer device, which also can be passed down through the cords, even in a situation where it's very, very difficult to see the cords, and then the tube can be passed down, the endotracheal tube can be passed down over the bougie. Video laryngoscopes actually allow us to use a screen and see exactly where we are. The laryngeal mask airway is a device that allows us to, in certain circumstances, intubate through the LMA and secure the airway that way. And then, if worst comes to worst, we have to do a surgical airway. And for that, we need to have a cricothyrotomy kit immediately available. And most of us dream that we'll never do this. And as of this moment, and I'm pushing my luck here, I have not had to do this. You should always keep difficult intubation kit immediately available in the operating room area. It doesn't have to be in every operating room, but it needs to be nearby. And you need to have a portable kit, because anesthesiologists get called all over the hospital to secure airways in people that other physicians have failed to secure. So emergency room, intensive care unit, cardiac arrests on the wards, we get called to these on occasion simply because our colleagues in other specialties have failed to intubate the patient. There's a difficult airway algorithm. Most anesthesiology societies have a difficult airway algorithm. The American Society of Anesthesiology has a very extensive one. The only negative thing I can say about it is it's probably too extensive. It's hard to memorize. The Canadian Anesthesiology Society has a very simple algorithm. It may be too simple. The UK has the Difficult Airway Society, which is a society that is devoted to coming up with better ways of dealing with difficult airways. And one should definitely look at their webpage and be prepared to deal with a difficult airway. So be prepared in any difficult airway to call for help, and to call for help early. Get people in there to help you. Because if you don't call for help and you get into a situation where you cannot intubate the patient, you may be responsible for that patient not surviving. So if you're unfortunate enough to not be able to intubate despite help and all the little bits of equipment I've mentioned, remember that what we need to do more than anything else is maintain oxygenation. And in some people that it is impossible to intubate, it's still easy to do that bag and mask technique and give them oxygen and provide them with satisfactory oxygenation until you either wake them up or you figure out some other way of getting a tube in. Then, if you have trouble intubating, you can then utilize one of the airway adjuvants that you have available. Try to use it. Don't panic. If you can ventilate the patient by bag and mask, the patient's going to be fine. As long as they're oxygenated, they're fine. So don't panic. There's a tendency to get really frightened in this situation. Most of us get a real tremor, so that's part of the reason why you need help. Try twice. The first time, just use your regular technique. The second time, adjust the head position, make sure it's optimized. You may want to raise the shoulders a little bit. You just want to optimize the position, put a stylet in the tube, consider using one of the adjuvants I've mentioned earlier, and have another look. You should only try twice before you move on to a major adjuvant, such as a video laryngoscope, and you should start thinking of whether you're going to end up going to a surgical airway. The nightmare comes when you can't intubate and you can't ventilate. So you make an attempt to intubate, can't get it in. You try to ventilate, bag and mask, can't ventilate. That is a disaster, and you need help instantly. So scream for help. Get some people in to give you a hand. You cannot waste any time in this situation. Try a second time to get the patient intubated. As I said, reposition, get in the best position. If this fails, immediately use an airway adjuvant, such as the LMA, and this would be my personal choice. If ventilation is now possible, and it often is after you've placed an LMA, relax, stand back, reoxygenate the patient, don't panic, and then consider using the LMA as a device through which you can intubate, or consider using a video laryngoscope. If the patient cannot be intubated or ventilated and oxygen saturation is drawing, you must go to a surgical airway. And to do a cricothyrotomy, you must understand how to do it. Or to do jet ventilation, you must understand how to do it. So you must study those techniques before you get into this trouble. It's too late to learn when you can't ventilate and you can't intubate. Call for surgical help to do a tracheostomy if a surgeon's available. But in honesty, you should probably do some surgical intervention yourself, either a jet ventilator or a cricothyrotomy. And then when the surgeon comes in, he or she can do a proper tracheostomy and take their time and do it properly. So an awake intubation is a way to avoid all the unpleasantness that I've talked about failed intubation, but of course in itself is not the most pleasant thing in the world. And for a patient, when you first talk to them about the fact that you're considering doing an awake intubation, the response is often extremely negative. You should have spent some time on a simulator before trying this on a patient. You should watch a senior colleague do an awake intubation and try to learn from that individual. And if you're in your training program, this is an excellent time to observe people who have more experience with this kind of thing than you have. Read and study books that describe awake intubation techniques. There are a number of different ways of doing this. And some people like to do a superior laryngeal nerve block or a transtracheal block with local anesthetic to reduce discomfort to the patient and reduce reflex activity. I personally do it a different way, but it's not to say that my way is the right way, but this is the technique that works for me. So the first thing I do is I get the patient to gargle, usually 2% lignocaine, lidocaine, as long as possible. I nag at them to keep gargling, and when they can't gargle anymore, they can swallow it. And that has the property of creating some local anesthesia in their oral pharynx, in the back of their throat, and some of it may pass down through the cords and give them some upper tracheal anesthesia as well. Provide a little bit of sedation. Usually little bits of midazolam are sufficient. Talk to the patient constantly. Tell the patient what you want them to do. Grasp the tongue gently, usually with a gauze in your fingers, and pull it forward as far as you can out of the mouth without causing the patient pain. Dribble little bits of 1% lidocaine over the tongue and down into the throat, and have the patient breathe deeply. Tell them that you really want big, deep breaths. When the gag reflex is lost, and this happens fairly quickly actually, use your fiber optic bronchoscope through the mouth or through the nose. But if you're going to use it through the nose, you have to prepare the nose with a substance that causes vasoconstriction, such as phenylephrine or cocaine, which reduces the bleeding associated with it. Before you pass the bronchoscope, make sure you've loaded a suitably sized endotracheal tube onto it. When you see the vocal cords, stop. Don't go through the vocal cords until you've injected another 2 or 3 mils of 1% lidocaine through the bronchoscope onto the cords. The patient will cough, but they'll cough once and then the cords will relax. You'll then be able to pass the bronchoscope through the cords without bothering the patient. Take it down as far as the carina, where the 2 mainstem bronchi break away from the trachea or from the larynx, and spray that as well. The patient will probably cough one more time, and at that point, you're ready to advance the endotracheal tube. Sometimes it gets stuck at the cords, and you need to turn it a quarter turn to advance it. But usually you can advance it right down the bronchoscope into the patient's airway, and without a whole lot of trouble at this point, and they're usually comfortable. Take out the bronchoscope, inflate the cuff on the tube, hook up to your anesthetic machine, and make sure that you're getting CO2 back. So check your end-tidal CO2 monitor. Once you're sure you're getting end-tidal CO2 back, you know you're in the lungs, you can then induce the patient and start ventilating them. So in summary, we've talked about the anesthetic machine, the equipment we use in anesthesia. We've talked about the monitors that we use, both necessary monitors and monitors that we can use according to our own judgment, according to the condition of the patient. And we've talked about the nightmare, the difficulty of intubating a patient, particularly that frightening situation where you can neither intubate nor ventilate the patient. From this, hopefully you'll be much better prepared to deal with the airway problems that are common in our population and successfully treat patients.